meningioma with cystic component.
Yes, meningioma with cystic component and extensive sclerosis. Is a marked thickening of the calvareal bone, which is evident also in the CT and is very dark signal in the MR. Yes. Bronchocephalic cyst will communicate with the ventricle, and there is no ventricle here.
هو cystic lesion.
Yes, it is. It is a cystic lesion, but it is intraaxial. Actually, this cyst is not included in the previous lectures because of its common presentation in the clinical practice. I included here, and this is known as the neuroglial cyst, which is the simple cyst of the brain. And you remember that I have mentioned before that there is no intraaxial cyst apart from hydatid, but this is wrong. There is a cyst which is well known, that is the simple cyst of the brain. It is called the neuroglial cyst. It is exactly similar to the arachnoid cyst, but it is located inside the brain tissue, and this is maybe considered an incidental finding. An intraparenchymal cyst of CSF signal and the CT density is a solitary unilocular cyst, and it has a smooth outline, and it shows no calcium and no enhancement and no diffusion restriction, commonly located in the frontal lobe, and the second common site is the temporal lobe. Then sometimes you got this lesion, which is located in the section below the level of the lentiform nucleus. It was called sublenticular cyst, but the actual name is now the neuroglial cyst or the glioependymal cyst. This is, let us say, simple cyst of the brain.
Meningioma.
Yes, and this is the classic appearance of meningioma by MRI and by MR spectroscopy. You know that meningioma is not a tumor of the brain tissue, so the N-acetyl aspartate is not present in the spectrum, and instead you got the classic appearance of the alanine, which will be inverted in the high DE spectrum. But in both conditions, then you got elevation of the choline. This is a classic appearance of meningioma. Okay, but there is hemorrhage. This is CT without the contrast, and this is CT with contrast, and this is a FLAIR image. And this is no. This is a brainstem lesion. And the brainstem, yes, brainstem glioma.
With hemorrhage.
With hemorrhage. It is uncommon for the brainstem glioma to produce hemorrhage, but sometimes you got so. What are the clinical or the clues for the diagnosis? One may say that this is hemorrhage and this is edema. No, and the most important sign, I stress this sign very much, is the exophytic extension of the tumor along the side of the basilar artery. And here, this is the basilar artery, and there is exophytic extension into the prepontine cistern, which is one of the landmarks of the tumor rather than any other kind of infection or hemorrhage. Then
Intraventricular hemorrhage.
Yes, intraventricular hemorrhage has three underlying causes. Number one is the presence of intracerebral hematoma that has extended inside the ventricle, or is the presence of subarachnoid hemorrhage passing into the ventricle. But whenever you see massive intraventricular hemorrhage with no evidence of intracerebral hematoma or no traces of subarachnoid hemorrhage, then you think of a small subependymal arteriovenous malformation that has been ruptured inside the ventricle, producing this massive intraventricular hemorrhage. Of course, in the exams, say this possibility unless you are pushed to say it. At first, you say that I have massive intraventricular hemorrhage, and this may be due to one of two, either hematoma or subarachnoid. Both are not seen in the imaging. Then the last to be suspected is the subependymal hematoma.
Epidermoid cyst.
Dermoid, you mean, huh?
Dermoid.
Yes. Yes. This is the dermoid because of the fat, and there is some fat globules inside the ventricle and also in the subarachnoid space. This is not blood because
T1.
yes, this is T1, and the blood may appear bright in the T1.
Floating upward.
Yes, very, very good. If it is blood, it will settle down in the sedimentation level inside the ventricle. But since it is floating on the surface of the CSF, you may consider fat.
Yes. Hemorrhage.
Yes, this is very important because many times I show this example in the exams and I got very strange answers. Hemorrhage in the cerebellum or the cerebellum is the second most common site for intracerebral hematoma after the temporoparietal area. Then if you see a hyperdense lesion in the cerebellum and you think of hematoma, and this hematoma can extend inside the ventricle similar to any other hematoma in the brain.
BXA.
BXA
Yes.
or
Yes, the answer is there, and actually I have tried many times to separate or to differentiate between meningioma with cystic component and the BXA. We have an overlapping findings in the form of the presence of an enhancing component that is dural based and frequently pleomorphic xanthoastrocytoma may be associated with dural tail, but in the diffusion weighted images, I said that in cases of meningioma, you got diffusion restriction of the solid component. And this was not, up to now, was not an accurate information because some of the nodules of the BXA may show diffusion restriction. Then the remaining two differentiating points are, number one is the non-homogeneous enhancement of the solid component, which favors BXA. And number two, the MR spectroscopy of the solid component, which will not show the presence of NAA in cases of meningioma, but NAA will be present in the nodule of the BXA. Then this is what I meant before. I said that if you got diffusion restriction, you think of meningioma because of the cellularity. But this was a BXA, and there is diffusion restriction of its solid component.
Neurocysticercosis.
Yes, this is the neurocysticercosis and the classic appearance of cyst and dot sign. And it is enough for you to detect only one lesion with a cyst and a nodule. And you consider most of the rest of the lesions belong to the same pathology.
Bullet injury. Bullet.
Intracerebral injury.
Yes, and
Bullet
this is
injury.
firearm injury or bullet. You see the course of the bullet either from here to there or the opposite, but you can see the track of the bullet. There is no hematoma that can cross all through across the brain parenchyma. Then you see the diffuse hypodensity of the brain tissue due to associated brain edema.
meningioma.
Cavernoma.
Oh,
Calcified
okay.
meningioma.
Yes, very good. This is actually a post contrast T1 weighted image where you got enhancing component with the evident dural tail, but the most of the lesion is not enhancing, and this is because of the calcium. And this is a good observation that if the meningioma is totally calcified, you may not got enhancement of the tumor itself, but you got only enhancement of the related meninges. By this, we conclude this session, and I thank you very much.
عفوا شكرا لك دكتور.
شكرا لك دكتور.
ان شاء الله يكون في الموديولات اللي جايه يكون الوقت اطول، وفي نفس الوقت نقدر نعرض عدد كبير من الحالات عشان تقدروا تستفيدوا بيها. واي حد عنده اي كومنت او طلبات او ملاحظات بيقولها للدكتور شريف، واحنا ان شاء الله نلبيها، ونتمنى لكم التوفيق دايما، وكل سنه وانتم طيبين.